Is Dr. Nadia. She'll be talking to us on the complications of ART. She has done her training in medicine in the Universidad de Mexico. It's one of the prestigious medicine faculties in the country, continuing her specialty in gynecology and obstetrics at the Western National Medical Center, one of the largest center in women's health in the country. Obtaining certification in gynecology and obstetrics the following year and immediately entering the National Autonomous University of Mexico, ranked the best fifth university in the continent, where she's performed her training in infertility as well as advanced gynecologic laparoscopic surgery and hysteroscopy. She has been immersed in the field of infertility since 2008, and she's been a part of the New Hope Fertility Center team since 2013. I bring before you Dr. Nadia.
Thank you. Thank you all and good day. I think I'll be stepping on some of the other talks this day, but I will try to make it as light as it can possibly be. Well, my talk is complications after assisted reproductions. Like the doctor was talking about the surgical ones, I will also be speaking about those and trying to approach all the different things that can happen. There are many complications that can come with assisted reproduction. The most common ones are, of course, multiple pregnancy. There's also being a trend towards associating IVF treatments with different cancers, especially the hormonal dependent ones. Of course, the surgical complications that can come with the oocyte retrieval, the long-term effects on the offspring of IVF babies, and of course, the well-known and very much talked about OHSS. I would like to begin first with the multiple pregnancy complication. Every woman that goes under IVF has a 20-fold increased risk in twins and about a 400-fold increased risk of having a higher order pregnancy, which is a 3 or more babies in the pregnancy. This very much comes from the trend to applying more than one embryo in the uterus. In the USA, 36.2% of the pregnancies of IVF is multiple. And in Europe, because of the trend is more towards applying 2 embryos, the twin is also very high. It's about a quarter of the patients that go under it, or 24%. In 2002, SART made a report that most of the transfer, about 62% of them, were doing a 3 embryo transfer and 32% were doing a 2 embryo transfer. So if we can see about 94% of all transfer in the US have more than 1 embryo, and that trend towards selective single embryo transfer is actually very much in need. Even though in Europe it's more of a 2 embryo transfer, also the large amount of twins, it's 24%, which means that about 40% of all the IVF babies will come from a multiple pregnancy. Most physicians and patients usually discard a little bit the potential problems that come with a twin pregnancy. However, the perinatal mortality in IVF twin pregnancies is 6 times higher than in a natural obtained twin pregnancy. We all know high blood pressure, diabetes, prematurity, and everything that comes with the treatment of those babies in the hospital. Most of the problems come from this fear, this paradigm that by applying 1 embryo, the pregnancy rate will be very much affected or diminished. So the elective single embryo transfer has had a bit of a hard way. However, by a study by Maritaken in 2004, actually achieved with a single embryo transfer a pregnancy rate of over 34%, which actually comes very much closer to the pregnancy rate that we can offer, practically if not diminishing or abolishing the complications of multiple pregnancy. Very much importantly, this particular study was made in a selective group of patients, younger than 36, with good quality embryos that also had some embryos to cryopreserved. But with most of our patients, and rather well selected, it can be done a single embryo transfer on day 2 and 3 and maintain the high pregnancy rates. Another issue that has come lately to the attention is the association between cancer and the IVF treatments. Most of the cancers, this is a particular graphic that I like very much in 2008, which is from the World Health Association. And what we can see is that the main cancers are breast and uterus, which are, of course, a female cancer, or at least in their majority. ovary and the uterus are also very high up there, which are very much the fears that the patients will come to us when they're doing an IVF treatment and they either had a previous problem themselves or a close relative that had a cancer problem. There are several issues that come with that. First, the medication that we're going to use, even citrate of clomiphene can also be associated just because they produce a hyper or superovulation, and that has been very much recognized as an issue in ovarian and breast cancer. Of course, with that superovulation and that increased number of follicles, the level of estradiol and progesterone will also be high, which is also one of the issues when it comes to already having a small cancer or a cancer that has not been detected. These increasing hormones will make it advance much more rapidly. And of course, well, the relationship that has come in previous studies, even though the authors have been very, very careful with making it a statement, it has brought some concerns, especially in well-informed and bred patients. But according to this, talking about this, I actually found this very, very good article that was done in 2002 and published in Fertility and Sterility, which is over 5,000 patients that were followed in the US, where they actually have a very good registry of any other complications of cancer that might have come very long years after the treatment. In these over 5,000 patients, the incidence of cases was 27, and in that particular age group and in those particular group of patients, they would have expected a 35 case presenting, so which means that there were actually less. If we make this differentiation by every type of cancer, we can see that there's absolutely no reason to be concerned. And another important thing is that there are a lot of cancers that can be prevented or diminished with the protection that a pregnancy can give, like ovarian and breast cancer with breastfeeding. So even for those patients that are in risk, the benefits that will come from a pregnancy could also be very much taken into consideration. Another very important complication is, of course, OHS, ovarian hyperstimulation syndrome. Even before the use of very high doses of gonadotropins, there was already a presentation with citrate of clomiphene. Most of them, even with that particular medication, was about 8% in the moderate cases. The shift that we've seen has been towards the amount of severe forms that come with this. Right now, after in the IVF era, severe is actually not more than 1%. Most of the cases will be mild, between 20 and 33%. But as we can see, there's really not much we can do as far as treating them. What the best approach would be is to be preventive and to actually identify the patients that can have a problem prior to starting the treatment. First of all is age. Obviously, a younger patient will have a much more larger cohort of follicles, which would mean they would have a much higher response with a higher risk of with producing this disease. At some point, the body mass index was supposed to be, or they found an association. However, these days we've known that there's actually no relationship. It's more of a sensibilization of the ovaries, regardless of the body mass index. The presence or the past allergies of the patient, it's something that we usually don't take much into consideration, and of course needs more studies to actually make a firm statement. But because of the pathophysiology of OHS, which involves a lot of cytokines and inflammation points, allergies has also been very much identified as one of the things that should be taken into consideration when talking to a patient. Of course, the etiology of infertility. When we're talking about patients with only problem is tubal factor, well, we wouldn't really expect any higher response. However, it's very well known that in patients with polycystic ovarian syndrome, there's a much greater sensibilization to this medication, and of course a larger cohort of follicles for that particular cycle, so we would expect that. Even in patients that do not have the complete syndrome, that maybe just have the PCOS-like ovaries in the ultrasound, or just a hyperandrogenism, should have or do have a much larger prone to the ovarian hyperstimulation syndrome. Medication, there hasn't really been also anything that we can actually make a firm statement about. When we started using agonist and antagonist, there have been some studies that said that neither the use of either one of those medications should increase it. However, since we started using agonists, because it desensitized that first approaching the ovaries, even though there's no particular record about it, the amount of severe forms of OHS has also improved in a 6-fold way. So, The dosage is actually also not something to consider it, since most patients actually have a much higher sensibility towards the medication. We've seen that even though we give a less dose or a minor dose, they will still have a much higher response, and they're more prone to this syndrome. The exogenous use of HCG, well, it's also very much established, the relationship between the HCG and the ovarian hyperstimulation syndrome. So one of the things, or the good things about using an antagonist protocol is that we can do the triggering with the agonist, which also reduces the probability of having this syndrome. And of course, with the responsive stimulation, ultimately the patient that has the more risk of having this is a patient that already had this syndrome once before. So what we would usually recommend, of course, with an individualization of the dose and the medication, would of course use what we call the mini IVF or IVF light or a mild stimulation ultimately. What we suggest is more a combination of clomiphene citrate with gonadotropins. By diminishing the amount of gonadotropins, we also diminish the amount of follicles that grow, the amount of estradiol, and of course, well, this will of course decrease the probability of having OHS. Even though the level of estradiol has not been, is not a one only factor, we've seen that patients that had over 6,000 level of estradiol at the moment of the retrieval also have about a 4-fold increase in risk, as opposed to patients that have less than 3,000 of estradiol on that particular day. Like I said, I'm going to be stepping on some of the talks, but well, pelvic infection and bleeding, of course, is also one of the probable consequences of oocyte retrieval. Of course, the bleeding increases the risk of being an infection. Most of the bleedings that we deal with are mostly vaginal and usually are practically done by the time the patient leaves the OR. However, there should be another check or a vigilance according to this, because some of the bleeding might be intraperitoneal and we might not detect it on time. There's a particular protocol or study that I really much like, because it was over 7,000 oocyte retrievals done in a hospital in Rome, where even though the percentage of complications was actually very, very slow or very small, pelvic infection was about 0.03, and ovarian abscesses was even less than that. It was very important to say that all those patients receive a very good prophylaxis dose of about 1 gram of ceftriaxone, and even some of them, when there was bleeding, received another dose after that. And regardless of the antibiotic, most of them, or they all presented with ovarian abscesses. So even though it's a good approach, it's not something that we can consider it as being that one treatment that we should do, because we give them antibiotics and then it's done well. They can still be presenting any of these particular situations. Of course, bowel or urinary tract infections, it's something to consider. Most of the bowel damage that we do, we will not see, because they resolve practically spontaneously unless it's a very large lesion. And urinary tract infections, lesions, will also be very, very rare. There has been some fistula reports. However, because of the ultrasound-guided form of we do this procedure, it's also very rare that this happens. First, ovarian torsion is also very, very rare. It's 1 out of over 1,000 oocyte retrievals, mostly due, of course, to the enlargement of the ovary. Most of them will occur several hours after the procedure, especially in patients that had a much higher stimulation and they continue to form cysts afterwards. They can also have an ovarian torsion. One of the things that we usually rely on is the ultrasound Doppler, but however, we've seen in all the in a particular study also that has over 200 torsions, that most of the Dopplers in those studies were normal. Over 60% of them were normal, and they had an ovarian torsion. So even though it's something that will very much help us, well, it's not something that we can definitely use. Definitely, the clinic will be the thing that will tell us whether or not there's an ovarian torsion. Once we are in the OR, there are several ways to go ahead of this. One is a conservative one, especially in patients that already had one ovary and we do not want to take that other one away. If we can see that the tissue is not necrotic, we can just detorse it and put it back into place. We can, first of all, have close observation and tell the patient that there's a probability that we're leaving some necrotic tissue behind, so there she might need another intervention, but we're trying to save that one, that ovary that she has. And of course, the oophoropexia, which would sustain the ovary towards the uterus or the pelvic wall, also to prevent it from happening again. We can use absorbable sutures, so they will, after this time frame of major risk goes away, well, the suture will be gone. And another very important thing is, well, what effect does this have on my offspring? That's, at least for us, a very frequent question. What will happen, especially when the fertility issue is more of a male factor? Will this be inherited to my children if my baby is a boy? First of all, well, it will of course depend on what the problem is in fertility. If it's a Y chromosomal problem, is this cystic fibrosis, if just the male partner has it, or also the female. So there should be some genetical counseling as far as this goes. But one very important thing is the amount of congenital malformations after ART versus natural conception. This has been a very conflictive issue. Most people would say that the percentage is not really that high. However, there's been lately a report that it's over 5.4% versus 3.8% that comes with natural conception, with no particular change whether it was obtained by IVF or by ICSI. But in another report that was done over 1,500 cases of ICSI cycles, you can see that there's 1.4 versus 0.4 percentage of chromosomal abnormalities. So this is basically because if it was very much associated with the male factor that comes with a diminished amount of sperm and a diminishing motility. There's really no relationship when the problem in the male factor is morphology. So when these patients come to us, they should also be tell or counsel about this particular problem. Ultimately, as far as this goes, first, we should also tell our patients, and the oocyte retrieval is definitely a safe procedure, but they should be made tell in advance that there's, of course, like any other procedure, percentage of complications that can happen. And ultimately, what we want is one healthy baby. So maybe by diminishing the dose of medication, we will diminish the complication, because even if we have less follicles, they will need less punctures. They will lead to less complications, and also less multiple pregnancy. That will ultimately, all these will help us have one healthy baby to deliver to the couple. Thank you so much.
Thank you, Dr. Nadia.